Start to go. I'm an economist, and we've heard from great talk from my ex-colleague and good friend Andrew about how academics are thinking about youth well-being. But I'm an economist, as I said, and it seems to me that we need to think about all sorts of ways of tackling this problem. And we have a great panel here, and Julie and I have been talking a little while about this. I mean, the market. If you believe in prices move to clear markets or something, we need to think about what potential implications and what potential interventions there can be from the private sector. So we're going to hear from these great people. There's one online coming, and then afterwards, after lunch, we're going to then move to start to talk to the non-profit sector. So not just academics and not just practitioners here, market folks, because there's potential here that market folks will invest in things and make money from improving the well-being of the young. So we're all in this together. Let's talk about markets. Thank you.
Hi, good morning, everyone, and thank you to Dartmouth and Professor Blanchflower and the UNDP for having us here. I'm Julia Bernstein. I'm a Dartmouth alum, and I'm the Chief Operating Officer of Brightside Health. We are a provider of virtual behavioral health services, so we do therapy, psychiatry, suicide prevention, and an intensive outpatient program in all 50 states. We serve those 13 up, and I just announced that our teen program is live in all 50 states. And we work across types of insurance. So we're really focused on addressing the youth mental health crisis and the broader mental health issues at point of diagnosis and at point of care. I'm joined by two colleagues in person today, as well as one online. So I have Craig Lund, who is the CEO and founder of Mightier, which is a company that came out of Boston Children's Hospital and Harvard, so a good example of academic-private partnership. That uses biofeedback-based video games to teach children emotional regulation. It's a really interesting approach to allowing us to use tech to help us, to quote a previous speaker, as opposed to letting the tech use us. Ed Gaussen, who's the co-founder and president of Mightier Health, which is a really interesting company that partners with over 150 universities to deliver integrated mental health services to students, so really working through the educational system, in this case the universities, to address students. And then Sandra Duncan, who is on the phone today, is a healthcare technology investor who focuses on digital health, behavioral health, and social impact. Fun fact, Sandra and I met over 10 years ago trying to introduce a mobile addiction treatment app to a hospital system. So these are things we've been thinking about for a while and are really seeing bearing fruit. So in terms of the presentation today, I'm going to walk through a few slides that sort of contextualize our discussion in the broader context of today, and then we'll move to a panel. So if you're able to go to the slides. Clicker. Great. Okay, so one of the places to start is, what is the money that is flowing into investment in solutions to the mental health crisis? And one of my takeaways from listening over the past couple of days is there's probably a really good PhD thesis on how these investment dollars map to some of the curves we're seeing around declining youth mental health. And so on the left, we have overall investment in what we call the US digital health sector from, this is 2023 to 2025, and you can see we're putting over $10 billion a year into private companies that are addressing healthcare. And then on the right, you can see the data from an organization called Rock Health, which is a really great nonprofit that shows sort of how much of that money is actually going to US-based youth mental health startups. And so, not surprisingly, 2018, 2019, and then a huge spike for the pandemic. But as we start to see that drop in flourishing that we've been talking about over the past 3 days, investors are starting to notice it. So it's a really interesting correlation around folks seeing a problem and thinking about how do we bring new solutions, whether they're technology-based or care-based, to market to help folks. So this is a market map These are just some of the companies that have been built, kind of call it over the last 10 years, to address the mental health and youth mental health crisis. You know, and there's a lot of them, a lot of logos, a lot of marketing dollars, but some really interesting companies being built. And what I would call out, you know, you can see up here, this is the youth mental health market itself, and you can see Mightier up there, and I think Mantra's there too. And then this is a more recent map that was made in 2025. And what I would call it on the second map is if you look at the two areas I've circled, you have the youth mental health space, and then in the far corner, you've got that little peer support community box, and you've got kind of 4 companies, one of which actually just shut down, focused on building community online and focused on peer support. And so if you think about this whole map, the majority of the companies here are focused on treating patients at the point of diagnosis once they've gotten to a state of poor mental health. And then over on the side, you have a few companies that are starting to focus on, some of them do prevention, some of them do treatment, but they're kind of focused on the social isolation and the community piece that we've been talking about. Oh, this slide didn't show up, sorry about that, but we are seeing investment outside of the US as well. On the left, you have some of the public health initiatives we're seeing worldwide. On the right, and I can share these after, is a list of select funding rounds in European, primarily European, but you know, global companies building in the mental health space. Companies in India, companies in the UK, like Togetherall or WISA or IESO. And so there is funding, but nowhere near around what you're seeing in the US. And a couple of things that I would call out about the global companies is a lot of these companies actually started globally and actually have come to the US as a big market as they think about growth. I think about Togetherall or IESO or Kooth. The other thing I would call out is that, interestingly, the companies from the market map earlier that have been most likely to become international are those that serve employers. And so if I think back to the lecture this morning about the link between employment and mental health, you see these very interesting patterns around, you know, employers who have global workforces looking for global solutions for all mental health, not just youth, but sort of employees and their dependents. And so what has this gotten us? You know, we've built some really amazing things over the past 10 years, and the panelists and I will talk about what we're building personally as well, but we're seeing lower barriers to entry to starting a care delivery company or building a community app or trying to introduce a digital intervention. We're seeing kind of faster connection to care. We're seeing kind of early proof of the value. We're seeing, and then we're starting to see ROI, reduction in emergency room visits, you know, introduction of new modalities like things like VR therapy that nobody talked about, nobody imagined 20 or 30 years ago. And it's showing up in the outcomes. I mean, these are pretty important numbers. You know, we've reached 1 million students in the US by distributing mental health services through school-based programs. We've driven access up over 21% due to telemental health. This is amazing for the patients and the kids who need the care. And we're also seeing, you know, great outcomes for the people who need the care. I think, you know, the takeaway is that all of this is wonderful that we've expanded the system, but we still have a gap around prevention, not just crisis care and follow-up. And I think the reason for that, and we can talk more about this from kind of the investor perspective, is the funding structures aren't necessarily there for some of this prevention work, and I think this is where the public-private partnership becomes super important. So I think in terms of the panel today, we're going to talk about kind of 3 pillars around stigma, expanding access to quality care, and creating sustainable financial models that we think are important when you're building, you know, a commercial company or a private-public partnership to address youth mental health. I don't think we're going to have all the answers, but I'm looking forward to a good panel discussion, and then, you know, if we have time, we can take questions at the end. So I think given that, you know, so to start to transition into our questions, you know, one of the things that I think also tracks that chart of increased investment in behavioral health and digital health is the change in stigma around behavioral health, primarily in the US, and then I think, worldwide based on some of the research Danny showed us. And, I think back to kind of pre-pandemic New York 2019, walking through a subway station and seeing a massive photo of Michael Phelps in a Talkspace ad talking about, his mental health journey. And so, Ed, maybe starting with you, you've been building Mantra for a few years now, how have you seen kind of the overall change in stigma track this increasing investment and increasing focus on doing something around behavioral health issues, as well as the burgeoning youth mental health crisis?
Yeah, thanks, Julia. I think it's a great question, and ultimately, I think that there is, to your point, a great PhD study to be done and research paper around how exactly these investments have tied to the outcomes that we're seeing now. My point of view here is rooted in the work that we do at Mantra. So for some background, we are a virtual mental health company working with colleges and universities, and about 1.3 million students around the United States have access to Mantra through their campus. And so the data that we're seeing is that ultimately care-seeking behavior has really improved on college campuses. I think that anecdotally we're seeing students going out there, talking about their mental health, on TikTok and, really to their friends, and it's become sort of this, thing that ultimately students are willing to talk about. But I think if you start sort of going a little deeper and going into the data, it's easy to look at this and say, okay, well, we've solved the problem. Turns out that there's still disparities between, what we're identifying in surveys and then who's actually showing up in care and who's actually following through in mental health support. And the data shows that, students from, lower socioeconomic backgrounds and students from, populations that are historically marginalized are less likely to show up in care, to seek it out, and arguably are the ones that need it most. And so this is shown by the Healthy Mind study, which I'll speak about later on. This is shown through the data that we see in our model, where as a virtual intervention that's able to, for example, hire clinicians of color and being able to reach out to these students on campuses who may not show up at a counseling center, where as they walk in, they may not see somebody who looks like them or that speaks their language. We're able to bridge a gap that exists in treatment. And so ultimately, I think what is really important to consider in the stigma conversation is that it's great that we're making progress towards reducing that stigma. I think that's also true where I come from in Switzerland and also in France, where I sort of grew up. It's sort of a phenomenon that's happening beyond the United States. But we actually need to look at the data of who's sort of following through in the interventions, who's showing up, and how do we reach folks that aren't following through, and what are the root causes of that? So I think that's an important conversation.
Yeah, I think maybe pulling on that thread a little bit about reaching the folks who aren't following through. I think one of the things, particularly when you're talking about youth mental health, is parental involvement and thinking about stigma the parent may feel as well. And so, Craig, knowing that Mightier works with kids, how do you think about the stigma question with parents and with kind of the broader question of family involvement in helping people get access to care or take preventative measures?
Well, it starts with our name. So it took us about a month. I can't tell you some of the other names we almost picked, but they were terrible. We picked Mightier for a reason, right? So we want kids, so many kids struggle with self-confidence, so many kids struggling. And they're often, I saw this in my nephew, who became physical to the point with our family because he was struggling with such anger. Guess what? He's a sensitive kid. He wants to be loved. He was in a family where my sister is a great parent, but he almost felt like he was the bad one in the family. How do you reverse that power dynamic? How do you bring a family together in a way that makes a kid build confidence? And so, truly, it starts with the name. Come be Mightier. It's something you can do as a child. And then, from day one, we learned very quickly a kid is not an island. I'm a dad. So much of our emotions reflect what we see around us and our parents. And so what we did is really center on how do you create a conversation between a dad and a son about anxiety? Incredibly hard. How do you make a kid not feel defensive in that moment, right? And so we really, from the moment we started, it was always like see the world through the kid's eyes, give a kid language they understand, and then invite the adults and everybody in on their terms, and then it creates these beautiful moments where all of a sudden a family's talking about doing this we have this little game called Fishing for Feelings. Everybody has to play. Next thing you know, a mom and a kid and a dad are sitting around a table and they're fishing out feelings, and they have to describe a time where they felt anxious or upset or annoyed. And it creates this beautiful real world connection, by the way, through the power of games. And I will make a plug. We use video games as well, which often it's video games bad. Well, guess what? I mean, we're using all kinds of technology right now. It's not the medium, it's the goal. I think our technologists have failed us, especially in the area of mental health, because they have the wrong goal. If you have the right goal, how do you create a beautiful moment between a parent and a child? Then use the medium in front of you to try to reach those kids to create those beautiful moments. And that's what we spend all day, every day trying to do, and to really make sure these kids feel a sense of confidence and make sure families, the whole unit is viewed as something we can help foster a relationship with. It's not a separate kid-parent solution.
Yeah, I think there's a lot in there to pull on, and I think one thread is this idea of using technology in a way that reaches people, but also thinking about new communication modalities. If kids are used to social media, and we talk a lot about this as we think about the content we provide to our teens, is do you have to move away from a PDF to a 60-second video, because that's how kids are used to receiving content. So I think there's a lot in there. I think maybe Sander, thinking about sort of this question of how do we use technology for good, how do you think about this as an investor and also as someone who's worked on the health system side, finding the right tools, the right technologies, the right interventions that can empower folks who either need care, who may be on the path to needing care?
Yeah, by the way, I'm glad you mentioned the parental aspects. I want to come back to that later on the panel. It's important and I think often overlooked. By the way, can you guys hear me okay?
We got you.
Okay, great. Sorry I couldn't be there in person. I'm an investor, so and I'm an investor specifically in startups. And technology is important, business models are important, but in the startup world, the most important thing for me to think about is the team. And early stage investors often talk about mission and mission-driven founders. Mission is a value of mine, but it's not necessarily a core value. I think a lot more important to me is almost a level of authenticity. And when we're talking about stigma and how to shift narratives in this market, that quality of authenticity in the founding team is critical. And it's something that I think drives very innovative technology and very innovative business models and the ability to build really impactful businesses for a high need population. And I've seen in my career that founders, particularly in the mental health space, who are vulnerable with their own struggles and normalize their own struggles to an extent, bring a level of authenticity to bear to the businesses that they're building, and can be much more successful for themselves, their investors, and ultimately the patients that they're serving. We co-founded a business focused on serious mental illness about 3 years ago called Flock. The founder himself suffered from severe bipolar disorder, had been hospitalized in the past, and led, again, in a very authentic way with his own experience. And going to market with that narrative and a lived experience was absolutely critical when talking to all constituents around the company, ranging from the big health insurance companies that we were looking to contract with, the health systems we were looking to contract with, and ultimately the team we were looking to build out, bring on, and the patients that we were serving. So I look for that level of authenticity in the founding team and all the people around the company. I think that's critical. And I guess just briefly too, I think there are multiple vectors here, and to what drives mental health, and ultimately what drives kind of a stigma in the business. There's certainly the genetic vectors underpinning some of these illnesses, but there's also environmental ones. And I don't think you can ignore half of the population when you're thinking about building a business or a technology or a tool. And I think we'll come back to this later in the panel. And my co-panelists just mentioned this a bit, but the family dynamic is critical to think about, how we develop narratives around parents, shame and guilt with parents on their child's health, and the perniciousness of that is very critical. And I think normalizing some of this for parents is a big step forward toward reducing some of the stigma in this market.
Thanks, Sander. And I'm going to add a question on our stigma category, which is, you mentioned bringing people who have suffered from mental illness themselves into the process of finding solutions. And if I think about the conversation today, I feel like every few weeks I see an article about a 15-year-old who's dropped out of Harvard to start a company and raise a bunch of capital. And so I think there's an interesting follow-up as we think about the principles to address youth mental health that come out of this around involving the folks we're hoping to help in the solution. And so, I guess for Craig and Ed, how have you thought about involving people in what you're building?
Well, I'm happy to go first. I think the thing for us is it starts with the interview process, and we're 7 years in now in building the company, and you make mistakes along the way in terms of hiring, but clearly outlining your values and your leadership principles, and ultimately understanding who are the people that you want to have along in your journey, and why are they doing this, and why do they want to join the company. And so I think screening for that and being able to be intentional in the interview process is extremely important. And then we also have a lot of individuals who are obviously customer facing, that speak to universities every single day, and I think for us, if they're going to be stewards of the company's image and mission, and they're going to go out there and have those conversations, back to the point of authenticity, that's something that's incredibly important. So when we talk to our sales team, I tell them, don't go out and tell my story for building this company. Tell your story for why you decided to join the company, and talk about why that matters. And everyone pretty quickly comes up with why this is so important, and I think it's compelling.
Yeah, that's great to hear. So I think now we've established kind of how stigma has, or Sander, you're muted.
Someone has muted me.
I think you're now unmuted.
Yes.
I'm on. Just to click on that, I think a lot of an important underpinning to reducing stigma is conversation. And I think what he just said it resonates. I think when you lead with lived experience and your own lived experience, it starts a conversation. And I think I've often been surprised with how many people at large health systems or payers or anywhere in the ecosystem, either themselves or someone close to them, had a experience or lived experience with someone with mental illness. And I think that's absolutely critical. That resonated a lot with me.
I will just add, maybe, I think it's helpful also. So personally, the fact that I'm on this stage would have been unimaginable to a 15-year-old Craig. I used to have debilitating panic attacks. But I actually think it's helpful to have a company that, we really screen for compassion and empathy. Like, I don't think, and it's often helpful, frankly, to have somebody who's a step removed to look on the outside and to think about it. And one thing we do as a team is we actually have kids come talk to us, which is super cool. So they feel like they're a superstar. We put them in front of a whole company and have them tell stories about their own experiences. And so that always grounds us when I'm kind of too business focused. Listening to a 7-year-old who's struggling with autism, what it means for their life, really grounds us as a team. So I think it's in the ritual of how you make sure you're listening, especially to the kids you're hoping to serve.
Yeah, I think that's a really great point. And I think there were some Hanover High kids in the audience this morning. So, I'd be curious to get their reactions as well. So, thinking a little bit about, the next thing that we've identified as, a driver of innovation here is this question of access to quality care. And, we know that while access has risen in some regions, we still see globally 75% of youth mental health needs go unmet. And, there's sort of this emerging population affected by, all of the things we've been talking about today. And so, I guess one question, maybe, Sander, curious what you're seeing and how you think about, reaching folks before they get to a diagnosis, before they're, the almost 18% of kids who come to Brightside and endorsing suicidal ideation out of our patient population. And so, how do we start to think about the folks whose mental health is suffering because of social media or because of some of the things we've talked about today? And what do we do, especially since, at least in the US, and I know globally as well, a lot of healthcare systems treat at point of diagnosis, not before?
Yeah, good question. I think about this in two ways, and the companies I work with certainly do. One is through technology. There are tools available to us today that weren't even available to us 24, 36 months ago. I've seen some teams doing remarkable things on top of various foundational models, LLMs, with predictive tools. There are a number of studies. I'd be glad to share any of them with folks after the panel, but that show in a demonstrable empirical way that you can, for example, with someone with serious mental illness, based on very simple patterns on their phone, how frequently they're texting, for example, how often they're picking their phone up, with predictive models and technology running on the phone, you can predict with a pretty high level of certainty if they're going to have a manic episode within 30 or 60 days. Sounds simple, but the technology behind that is not, but that is something that was not possible 3 or 4 years ago. And if you're talking about preventative care as opposed to point of crisis care, I think that there is a remarkable suite of capabilities available to us today that weren't available even somewhat recently. And I'm very excited about companies that are leveraging those technologies into new products and services going forward. I think the other, when we're talking about preventative care, particularly among the youth, we talked about this a moment ago, but I think more deliberately, creatively leveraging the care circle around these children and adolescents, namely the parents. And I'd be interested to see someone build a company that actually, in some ways, doesn't touch the adolescent or youth directly, but focuses on the parents and really enables them with tools to manage their children's mental health if there's a known issue, or have the tools to see if mental health is developing early and get the child the resources that they need, and either outside of the 4 walls of their home or within it. I'm on the board of a nationally scaled pediatric autism care management company. We are not ABA therapy. Our care model is centered on enabling the parents to, alongside occupational therapy and speech therapy, take better care of these children with kind of mid to high range autism. And the entire business model and care model for the company is founded on the simple premise that children are genetically wired to learn from their parents more so than anyone else in their environment. And I think that there's a lot of creative, innovative work that you can do on that simple premise around kind of youth and mental health, and particularly in the context of preventative care and that kind of silent middle, Julia, that you mentioned.
Yeah, I think that's really interesting. And, to pull on something you've mentioned there around involving caregivers and parents, I know John Haidt spoke yesterday, and he has all of his principles. And I do think there's something there. I mean, I've got a 4-year-old and an 8-year-old, and I don't know what the rules are for screen time. I don't know what to do. And, I've read his books. I've read all, I've got a stack of books on how to responsibly use technology quite high on my bedside. But I do think there's a really interesting education piece as we think about, all of the environmental factors. And I think, giving the people, I think we've been talking very macro, and I think these micro interventions of, how do you work with parents, schools to teach responsible use? It's almost akin to some of the research around reading in the home and how powerful that can be for child development. So I think, we've been talking, one of the other things when you're building these types of interventions, whether they're digital or whether they're live, is how do you think about measuring quality? And so that's something, we talk a lot about at Brightside, and I think we all do, is, it's not just enough to get people into care, you have to make sure the care works. And so measuring outcomes is both an important thing to do, but it's also important to help translate and validate that what you're doing in one country or one community can be applied globally. And so I think, Ed, given you've got experience outside of the US, how do you think about, what we're doing in the US, both from a prevention and care perspective, and, what translates and what might we need to think about differently?
Yeah, so, as somebody who's experienced, sort of and observed the mental health care systems, and where I was raised in Switzerland, and went to college in Canada, started my career in the UK, and obviously been building Mantra here in the US. There's definitely, obviously cultural differences that you see across the board. There's a general trend around, as we talked about earlier, the destigmatization. But I think some of my most kind of like relevant data points that I can provide for today around this issue are specifically around the types of different populations that we treat on college campuses. And I think if you zoom out, that can help you understand how that might differ in the world. So it's very important to think about and not confound the difference between solving for the root cause of what's happening to be able to prevent mental health, and then the modalities, right? We could say, okay, well, peer support has worked in this population, and it's a scalable intervention, so we should do it around the world. Or we should do this with suicide prevention training. Turns out, attempting suicide is illegal in, I think, 20 countries around the world. And so maybe such a program wouldn't be that well received, in some Islamic countries. And so I think that's something to keep in mind, is, trying to really think about ultimately what are the root causes of the mental health issues in certain populations, and then trying to solve from there. And so, for example, when we work with community colleges, the core issues there, around mental health is really based on basic needs, right? So you think about the Maslow hierarchy of needs, and the physiological needs, whether it's housing, food, financial security, etc. Those are the things that are causing the stress, and then that stress turns into distress, and turns into much bigger needs around mental health support in the medium to long term. But that might be true in other countries around the world, where we also work with Ivy League institutions. We work with private high tuition institutions where the freshman class of 2025, I think some of the data point I received from one of our institutions was that 75% of students walking on campus that year had received therapy in the past. 75% of students. And I believe the average from the Collegiate the Center for Collegiate Mental Health study, which comes out every year, it's the biggest study around mental health in higher ed, is that the national average is at about, I think, 65% in terms of students who walk into a counseling center who have received therapy in the past. And so, a very different kind of data points that you see in terms of what the needs are, what the stresses are, depending on the population. And so I think, to take it back to the question, the interventions, the modalities are there. I think a mix of virtual and in-person is important. The data proves that as well. But ultimately, it's about tailoring the interventions to the root causes and what we're seeing in different populations.
Yeah, I think we're in a bad situation in two ways. One, and I'm sure I've read a lot of Jonathan Haidt's work. Our values as a culture are really depressing. And I think there are root challenges, crisis of meeting, all these things that a lot of kids and adults feel. And then when I talk to health plans, the issue is, okay, we're going to just give them more therapy. Now, no offense to my therapy friends, and also Mightier, we can't solve all problems. Like, the answer is just not access to more therapy. And I think one of the issues we face in health plans is getting them to, first of all, they don't even measure the impact of health, of therapy, usually. Sometimes they do. Good partners like Brightside, I'm sure, are giving them data. But they're basically just throwing money into a black box to, in theory, help these kids, and they're getting no data in return that says kids are actually being meaningfully helped. And so part of this is starting to at least show the efficacy or not of what they're already paying for, which is they're spending a lot of money on these things. But the biggest challenge like we face, and we have a lot of clinical data, we were born out of Boston Children's, randomized controlled trials coming out of the ear, is even getting them to take the next step down where, we're used to paying for therapy. This other thing, I don't really understand what that looks like, and it doesn't fit my model with how I pay for things in the world. And we say, well, wait a minute, you don't even have data showing the thing you're paying for works. And so we both simultaneously have a health system that has totally screwed up incentives, doesn't even know how to measure impact, and is just stuck in a status quo and unwilling to bend towards new ways that could be helpful. And on the other side, a culture that's sort of dropped the ball on a lot of the core foundational things that provides a meaningful, flourishing life. So not to be too depressing, but I think part of it is, at least with these health plans, we're trying to measure more, show more. That's not effective. That's not working. You're already paying for that. So why not try something different? How far does the health plan need to reach down into solving, giving a 9-year-old meaning in life? That's a big question, philosophical question, but at least starting to measure hopefully opens eyes. Dollars are already being spent. Start to move those dollars to hit more core need. So maybe peer-to-peer support, other things like that, are more effective than therapy in many cases, or whatever the particular instance is, because it's getting at a root cause issue as opposed to just hammer nail with therapy.
Yeah, so I think we've started going into the role that health plans, and both in the U.S. where we have what we have, as well as companies where you have a single payer. But before we go to that, Craig, I think Ed provided some interesting perspective on kind of how Mantra's customer base almost bifurcates, on some of the socioeconomic and demographic questions we've been talking about, and the different in access and care. And as opposed to the university system, you work within the K-12 system, which ideally should be a lot more equal in terms of access. What have you seen there, and what lessons have you learned that are hopefully more applicable about both prevention and treatment in the school system?
Yeah, we do a lot of work with Medicaid, and stigma matters, language matters. We spend a lot of time trying to go deep with families, and we're serving a Hmong population in Minnesota, Somali population, and even down to the marketing materials you send in the mail. What does that mailer say? How do you talk to a family in that way that hopefully makes them trust you, gives them a chance to help their kid down this path? So it's really in the weeds. Like, this stuff is hard, and it requires an incredible amount of nuance, and you can't just make blanket assumptions. But thankfully for us, about 40% of kids on Medicaid. If people don't know that stat, it's kind of shocking and terrifying. And it has given us an opportunity to try to, one of the powers of games, honestly, is that they're fairly universal. But then using that kind of more positive, reinforcing language, and then tailoring it to different communities' needs to be able to talk to people in a language they understand.
Yeah, I think that's really helpful perspective, and I think it's interesting, just thinking about, it's not just the video game or the pack of playing cards, it's not just technology that's driving connection, it's the infrastructure we're building around solutions that allow them to be effective. So, I think coming back to, where you were going, which is the question that I always ask when, folks come up with amazing ideas in healthcare. It's, how do you get paid? And how do you think about reimbursement? How do you think about private funding, public funding, and funding prevention, not just treatment, which seems to be our normal way of working right now? So, to switch to talk about that a bit, Sander, how do you think about, to kind of Craig's earlier point, that sometimes the data isn't enough to move the funding model or to get people to try something new? How do you think about mobilizing public and private investment in prevention first models? Who are you working with from the investor seat? How can we work together to kind of co-fund solutions and sustainable innovation?
It's a hard question, and there's no perfect answer, and I think there are multiple answers to it. I think about this from a macro perspective and a micro perspective. On the first front, for better and for worse, everything in the U.S. healthcare system starts with policy, particularly when you're talking about children. To Craig's point, almost a majority or a huge plurality of children are on Medicaid, CHIP. And how companies and providers are reimbursed for interacting with them is fundamentally dictated by policy at the state level and to an extent in DC. My business partner at our family office is Chris Klomp. He's a exited health tech founder. He built a company called Collective Medical. He's on sabbatical from our firm right now, running Medicare in the Trump administration. And as a side note, I think we should all be blessed that there's a technologist and entrepreneur overseeing a $2 trillion budget that impacts millions of Americans. But his primary goal right now is trying to inject some sense of business logic into federal and ultimately state policy in U.S. healthcare. I think, again, a lot of what happens at our level, at the company level, has to start in DC or in Sacramento or wherever the state policy is dictated. At the micro level, healthcare in the US is fundamentally a local business. And when you're talking about bringing disparate parties together across public entities, for-profit entities, nonprofit entities, that has to be thought of in a local manner. And when I say local, I sometimes mean county level, sometimes municipalities, certainly at the state level as well. And what is true in California, healthcare population for children in South Central LA is going to look a lot different than a adolescent population in Memphis, a lot different than an adolescent population in Fargo, North Dakota. The resources available across those three constituents, public, private, nonprofit, are going to be different. And I think if you're a company trying to drive change, you need to be aware of that dynamic in the US healthcare ecosystem and really focus in on where can I have impact at the municipal, county, state level? What constituents are engaged around these issues within those concentric circles? And what incentives are important to each of them, and how can I bring them in? The fear I have as an investor is a lot of what I just described on the micro level is not terribly scalable. And so when I'm looking at founders, what's important to me is, do they truly understand that dynamic? And do they have some level of scalability within their platform that, to my best estimate, can work in South Central LA as well as it works in Memphis or whatever the case may be. And sometimes I think the answer to that is building businesses on a regional basis, just dominating the Southwest. And typically reimbursement models are going to be consistent across more local geographies, and certainly the populations underneath them. And I think the final point I'll make is ultimately getting paid in this ecosystem, and healthcare generally and mental health specifically, it comes down to a demonstrable, tangible, and clear ROI. Whether or not there's a payment model or a reimbursement model from a policy level available to you to get reimbursed. What I love about being a healthcare investor is these markets are massive. I mean, I'll be presented with what's considered to be a niche in US healthcare, but it's like a $50 billion niche. And there are several of those multi-billion-dollar niches within pediatric mental health. And there are problems everywhere at scale, even if there's not a well-defined reimbursement model behind it. But if you can show a clear ROI on your tool or service or combination of the two, there is going to be someone who has a problem within that giant end market who will likely be willing to part ways with dollars to pay for your service because they probably have an acute problem. That's my final piece of advice on that front for all the budding entrepreneurs in the audience.
Yeah, and I think you picked up on something really interesting in that, which is healthcare is fundamentally local, and it does need to be, as we were talking about earlier, customized and personalized and of the community you're trying to serve. But at the same time, we live in a global world, in a very tech-connected world, and we're all trying to build for scale. And so I think it's an interesting question around how do you deliver local and customized interventions, prevention, care, but put the infrastructure behind it so that you can scale those interventions from place to place and really have a macro level impact. And so I think that's a really interesting framing as, the conversation over the next, couple panels moves to what's next. To pick up on your ROI point, Ed, I imagine you get a lot of questions around ROI. You're also working with universities with lots of academics. So I'm curious how you quantify ROI, how maybe for our audience, have you partnered with academics and researchers to quantify ROI? And how do you tell that story that the care you're providing, to Craig's point, is actually care that's needed and having an impact?
Yeah, it's one of the things that I love about the space that we operate in within higher education, is that I believe that at least U.S. higher education has done such a great job at demonstrating and understanding the value of mental health beyond what it does at face value, which is extremely important. It's life-changing. It's obviously altering trajectories in a positive way. But if you look at the Healthy Mind study, which is really kind of the study that is most often quoted in terms of being able to talk about the impact of investing in mental health care within this population, that's a survey that's run on a yearly basis amongst institutions of higher ed to understand the baseline around mental health from their student populations. What they've been able to show longitudinally is that for every dollar that's invested of mental health support on your campus, on average, the return will be about $2 of saved tuition dollars from students who would have dropped out should they had not received the mental health care that they received through this investment. Now that paper obviously raised mental health care at the presidential level because obviously for many institutions around the United States, dropout is a massive issue, and so they're trying to think of innovative ways to prevent dropout, and mental health just so happens to be the #1 cause of dropout at this point amongst college students in the nation. But the survey and the data actually goes beyond that. It's not just about the dollars saved in terms of tuition, but it's also the lifetime earnings of that student that is retained. It's the impact on the tax base of the state. It's the impact on workforce development. It's the future reduction in crime and the burden on the police force that comes with that in the state. So there's all these trickle-down effects when you think about the positive impact of investing in mental health support, both in terms of clinical care and preventatively. And so I like to say that we're lucky to basically be in the space where that work has already been done for us. Now, we're trying to take a step beyond that and show that it's not just about investing the dollars, but it's about the quality of the program that you sort of build and the intentionality, and not every other program is built the same when it comes to mental health. And so we have our own data around this. 4 in 5 students that go through our care say that Mantra has helped them stay enrolled in school. And just about the same amount say that Mantra has actually helped them perform better in school. And so those are data points that ultimately matter when you're thinking about ROI and you're talking to decision makers and policy makers, because ultimately this is now an issue that has risen beyond just the presidential level of universities, but also at the state level. You know, I have a chance to travel a lot in different states and speak to decision makers, and you know, that having those data points, I think, is absolutely crucial, and is something that can ultimately solve a lot of issues in the state when you think about all these trickle-down problems.
Yeah, I think the problem is 95% of the payoff of mental health is not accrued to the health plan. So sort of like what you said, Ed, it's like, again, the incentives are totally screwed up. So I go talk to a health plan and I say, well, wait a minute, if I help this 7-year-old who's struggling with anxiety get better, the likelihood they're gonna be an addict, that they're gonna form meaningful relationships in their lives, 20 years down the road is 50% greater. They don't care. I mean, maybe they care as a human, but as a health plan executive, they do not care. Because they're literally telling me, if you can't show me an ROI in 1 year, I can't implement your program. And so I think we've got some economists in the audience. Maybe this is a call. I was a former econ student here at Dartmouth. If we could put somehow, we've got all this data, a price on emotional health, and then through policy, compel these plans to invest dollars, and then have the solutions that most impact that metric be rewarded in a market mechanism, because it is a public policy issue. Ultimately, the government's paying for all this. If you end up more likely to commit crime or are not a contributing member and end up, you know, on an employment roll, all these things, it's a societal challenge. I don't know how to do that, but if we could create a price for this, like almost like the carbon tax, but the inverse of it, a human flourishing price, compel the plans to pay for it, and then I go in the room and I say, I move these metrics more than therapy. Maybe Ed, as peer support, moves these metrics more than these other interventions, and now there's a way to actually get paid for it. Otherwise, I'm stuck with a 12-month time horizon with these plans. I can sort of squeak it out because I can show a little bit, you know, fewer visits to the ER and all these things they care about, a little bit less use of medications. But 95% of the impact I'm having on these kids' lives is invisible to them, or it's visible to them and they don't care. So that's the fundamental problem with mental health and the health plan system, is that the incentives are not there. And until we fix that, we're not going to really create a whole bunch of solutions that can, through market economics, have an impact on these kids' lives.
Yeah, and I think to extrapolate from that, I can imagine that data would be helpful for anyone who is funding anything in the behavioral health or youth well-being space, whether it's philanthropies, NGOs, governments, health plans, universities. And so I think that's a good thread to chase down. So, you know, I think I realize our panels, the standing between you and lunch, and then a very interesting afternoon. And so maybe a closing thought from everyone. You know, what's one takeaway from our discussion and from your experience as we think about, you know, the broader context of addressing youth well-being? You know, I think for me, and then I'll hand it to Sandra and then our onstage panelists, is how interconnected and complicated all of these factors are. I think we've talked a lot about who pays, who delivers the intervention, who supports the patient, how the patient accesses care themselves, and then, you know, the broader technology ecosystem, which I don't think we've touched as much on, but I think is ever present. And so I think that's, you know, something I'm taking away as I go back and think about the work that I'm doing, you know, is how do we make sure that we are being both macro as well as micro?
You took mine. Can you hear me?
Yep.
Yeah, Julia, you took mine. I was going to say it's this constant interplay between serving all constituents around the issue. It's a complex issue and it requires multiple constituents, from parents, the patients themselves, payers, providers, policy, and all of that plays out at a macro and micro level. And I think those that are successful truly authentically understand the interplay between all of those constituents, where the incentives lie, and how to build tools and services that speak to, you know, certainly not all of them because that's not possible, but prioritizing one or two and just really focusing on the interplay between them.
Yeah, I think for me, the biggest takeaway related to kind of the conversation we were just having around the importance of the healthy mind study within, the higher education space, thinking about the link between having the right data and having the right outcomes to be able to advocate for, funding within the different types of payers that might, support these types of interventions. And so really a call for, policymakers and philanthropies and academics to continue supporting research that is going to, help us with the data that's missing to support new interventions and to support payment for populations who are currently going underserved. To me, that's just something that remains an opportunity. We're lucky to have it in the higher education space, but I see it as a gap elsewhere. And I think you just pointed out with insurance plans, it's a big opportunity.
Yeah, I think I stole my own thunder. I don't know. My main thing is coming together and somehow establishing an incentive paradigm that gets mental health paid for, and then using the weight of policy to ram it down the throats of insurance companies. Yes, and then always like meeting people where they are and going deep with people to truly understand the depth of the challenge. Because oftentimes, again, it's like, oh, this will fix it. Just do more of that. And it's that thinking, especially in something as complicated as mental health, is almost never the case. I mean, the whole human is a very complicated idea.
Well, thank you to Sander, Ed, and Craig, and to Dartmouth and the UNDP for giving us this opportunity. I think it's been a conversation that I've taken a lot away from, and I hope everyone else has as well. And we look forward to continuing the conversation.
Thanks for having us.